So Swapnil, I was wondering if you could kind of just share with me a story of a patient that's changed your life.
Yeah, sure. I guess everybody will have always few patients that always get stuck with you. Sometimes for good reasons, sometimes for not so good reasons. And I because a lot of juniors are listening to this podcast, I want to share the patient who unfortunately died on my night shift as ICU registrar. And it was very interesting experience overall, and I was quite numb after that finished at night shift. So I started a night shift. I had like busy ICU, and I had like 2-3 new admissions coming through. All were sick, and this patient who was admitted just that morning while I was finishing the previous night shift. And the patient was basically around 53-year-old patient who was in detention center and was had a apparently collapse in the toilet and was brought to the emergency department. He was pretty much initially with GCS of 14 and remained GCS 14 to 15 throughout. And because...
So for the kind of students watching
Sure.
and stuff, GCS, it's your consciousness level. So 13, 14, they're speaking, but they're a bit vague. They're looking a bit drowsy. It's not, something's going on.
Yeah.
Something looks fishy.
Yeah, that's correct. So it was not very deemed very sick patient, but he was vague. He was from prison. He had obviously the prisoner guards were with him, and he had one episode of hypotension in emergency department. So they were a bit worried. Hypotension. So they admitted to intensive care, more of a HTU level of management. And I remember like I probably handed over in the morning, like this patient just arrived, probably there's nothing much for us to do. I came back on the night shift, and as expected, consultant cleared him to go to the ward. When I started the night shift, this patient started complaining indigestion and epigastric pain. And the nurse looking after him was probably one of the most annoying nurse in the unit that time. So everybody was kind of learned to ignore her in a way. And it was kind of sad in a way because anyways, so the patient complaining indigestion, so we said, okay, let's give some pantoprazole, give some antacids, and then try to settle. Then this patient wanted to sit out in chair, and I was the only registrar looking after ICU, and I had 2 other admissions which are very sick. So I was performing the central line insertion, and then nurse came back to me and said, you need to come and see this patient right now. And I was literally in the middle of central line. So I finished the procedure, went and see the patient. He was really uncomfortable, complaining chest pain. So we did an ECG, we sent a TROPS, came back pretty much normal.
Really?
ECG, there was some non-specific STT changes, but really not very significant.
Okay. So to kind of break that down,
Sure.
There's some ST elevation, but it didn't look like it was in the exact
No.
territory. So there's some markers that something might be going on in the heart, but nothing's clean.
Yeah.
Yeah.
I tried to do my own echo with the limited skills that time, and there was no windows available because he was quite a hefty, big
that
guy,
can be really hard.
and it was very difficult. So anyways, then he became a bit more hypoxic towards the end of the shift. So we did a chest X-ray, looked like APO, gave some Lasix, gave some...
So APO, the fluid building up in the lungs. Why? Multitude of reasons, but maybe the heart's not pumping well, so fluid builds up in the lungs. So given some Lasix, that gets rid of fluid.
And then obviously gave some non-invasive ventilation with CPAP. He responded quite well. By the time we came to handover, he was back to the kind of baseline with the nasal prong oxygen. He was quite comfortable. My concern was clearly not very happy because I cancelled the discharge, which was there before. So I went home.
So he never went to the ward.
No,
he was
never.
cleared for the ward.
Yeah.
Started to have these problems in the lungs and maybe the heart, and you've kept him there.
Yeah.
Okay.
And
Sounds like the right thing to do.
That's right. And I mentioned in the note, like maybe he will benefit from echo next day. So I went home, slept, no dramas, came back again. And this patient was still there, still waiting for ward bed, cleared by consultant. And in notes it says they didn't think there's any cardiac problem or anything. And then the plan was to just increase the antacid medications. And the same story happened again in the night, where again at around 11 o'clock in the night, he tried to do the same thing, trying to sit out in chair. And I was like, really, is it like the same thing happening again, with the prisoner guards around him? anyways, did the same thing, repeat ECG, repeat troponin, same values.
So was he short of breath again and desaturated?
Slightly short of breath. No,
Okay.
sats were still normal on that day, but
And he's off CPAP.
He was off CPAP.
Just
He was
nasal
just
prong
nasal
oxygen.
prong.
CPAP's pressured oxygen, yeah.
And the instructions from the consultant were like, really,
Yeah,
need to go.
This guy's fine, just get him out.
Don't do any extra
Yeah.
things at night, kind of thing.
Yeah.
And so I did a ECG, rang my senior registrar. So did all the right thing, and senior registrar came, had a look, same thing, no major kind of changes on the ECG, bloods or troponin. And then went to see another patient. In the meantime, the cardiac arrest buzzer went off, and then this guy arrested and basically asystole for throughout the cardiac arrest, couldn't revive, more than 45 minutes of CPR, and he died. And this guy was from, he was overseas. There was no family here. He was in detention center, and
it was a detention center for immigration.
yeah. And then
asylum seekers, yeah.
and then calling the family in middle of night at 3 a.m. to tell, and they couldn't even understand the language, was terrifying experience. And on one side I was shaken, I was numb, I was like, where did I go wrong as a doctor to start with? But also at the same time, I can't even now tell his family, and even family couldn't, because most of the time normally what we do in ICU is when they're started becoming sick or when they're about to die, we always give them family call before so that they visit or they can talk to them or phone or anything if possible. But obviously there was no any opportunity, all those things. And so obviously this case got evaluated quite in depth, and then this patient actually had a aortic dissection, and he died with a traumatic aortic dissection, and then that changed the protocol in the hospital forever, that every trauma patient needs to have PAN scan to not to miss these type of injuries where there is.
Was it a trauma patient?
Well, he had a collapse in the detention
fall.
center, but there was a history of the query
Right.
that there was some
abuse.
fights and
Wow.
stuff. So it was quite a kind of a case got stuck with me for my life.
And just so people understand, an aortic dissection is when your arteries have layers, and those layers need to stay intact so that blood flows smooth. And if the the inner layer, gets a cut in it from trauma, if you get moved around too hard, which sounds like might have been what happened, it can cause massive clotting and massive bleeding, and it's a horrible situation, very hard to treat.
Yeah, and I think as a junior doctor, that sometimes these experiences can be quite challenging and traumatic. And also in these moments, the one important thing is the documentation, because these cases can really quickly become very medical legal.
It's amazing how something so emotional can
Yes.
so quickly become so document.
Document,
That's the least emotional thing, but you've got to cover yourself.
Yeah. So always that's something. It was interesting and challenging experiences that you learn throughout your training